Good afternoon. Thank you for joining today's Association of American Cancer Institutes Physician Clinical Leadership Initiative webinar on minority recruitment to clinical trials. Our presenter will be taking all questions at the end of the presentation. You may submit your questions during the webinar using the Questions tab on the lower right of your screen. Questions will be answered as time permits. I would now like to welcome our distinguished presenter. Dr. Ruben A. Mesa is director of the Mays Cancer Center at UT Health San Antonio and Mays Family Foundation Distinguished University Presidential Chair. Dr. Mesa is also an AACI PCLI Steering Committee member. And now I will go ahead and hand things off to Dr. Mesa to begin the presentation. Dr. Mesa, are you with us?
Yes, I apologize. It cut out for just a moment.
Okay, well, you're welcome to go ahead and start the presentation when you're ready.
Great. Well, everyone, welcome. I look forward to us having a conversation here regarding both clinical trials and issues as it relates to underrepresented minority individuals going on to those studies. This is an area of both personal tremendous interest as well as one that has been central for the cancer center that I have the honor of directing, the Mays Cancer Center here at UT Health San Antonio, MD Anderson. Now, as we think about clinical trials in 2018, why is this an issue? First, we know that the purpose of clinical trials is really to inform our understanding of the biology of cancer, as well as to help aid us in developing new cancer therapies. And for both of these things to be successful, the populations that we include, whether it be on a biobanking clinical trial, whether it be on a therapeutic clinical trial, really need to be reflective of our population. And indeed, we have learned that there are many aspects that relate to ethnicity, that relate to culture, that have significant implications in terms of the development and progression of a cancer, the risk of developing, responsiveness to a therapy, even the pharmacogenomics in terms of how we might either respond, clear, or have toxicities from a therapy. So this diversity, as it gets included in our cancer research, is crucial. Next slide, please. So we're going to focus on a few different topics and certainly leave plenty of time for questions and answers, as well as a bit of chance for discussion. Indeed, as I present this topic, I certainly have looked to include information both from my center, but information that's been generously shared with me from other directors and other centers that face these same issues. Next slide, please. Now, as we think about cancer clinical trials, certainly this is an expert audience that likely has dialed in today for this webinar. But we recognize the tremendous spectrum that we put under this umbrella. When I say a cancer center or cancer clinical trials, most people jump to and think specifically about our interventional therapeutic studies of a patient who has an active cancer, i.e., they have a lung cancer, we give them drug X, the cancer shrinks, we evaluate safety and efficacy. And although that is a core aspect of cancer research, that really is only one flavor in the significant portfolio of cancer clinical trials. We all have the mandate of decreasing the burden of cancer in our respective regions, in our catchment areas for our communities. And that decreasing the burden of cancer begins with focusing on cancer prevention and augmenting cancer prevention, screening, and moving forward the science of how we screen for cancer. Next, of course, are the core aspects of cancer clinical trials. Those are the treatment control trials. Treatment trials as it relates to whether it be drug therapy, immunologic therapies, what have you. Symptom control studies, a crucial additional piece to this that I think as a field we are increasingly utilizing. However, I think there are still opportunities there. There's great opportunities for research in our care delivery, those models, delivering care remotely or complementing that with web-based approaches. Finally, there are many aspects that relate to the post-therapy period, whether that be, quote, survivorship care, that is a term that's very broad, that includes support, that includes palliative care, that includes the post-therapy care in individuals that no longer have a cancer as we look and screen for either recurrence of cancer, organ toxicities, risk of relapse, as well as secondary prevention of developing new cancers in those individuals that are, quote, cancer survivors. Next slide, please. Now, any discussion of increasing accrual on the cancer clinical trials clearly has to begin by acknowledging that accrual onto clinical trials is in and of itself challenging, let alone before we weave in the extra complexity of being sensitive to issues as it relates to culture, ethnic groups, etc. Why is it more challenging to put patients on cancer clinical trials? I think for many reasons. First, our eligibility criteria have typically become much more narrowed. A part of this is a recognition of the revolution that is individualized medicine in cancer, specifically genetic markers, mutations, etc., that help to try to match a therapy with a subpopulation. Additionally, many studies have become much narrower as it relates to adequacy of organ function, the presence of comorbidities, and even prior therapy exposures. The second that I would highlight is the impact of randomization and the internet. Increasingly, patients will likely investigate
Dr. Misa, I think we lost you there.
Study. Most certainly, you can assure me that I will be able to be on arm B. Third, there are more non-experimental treatment options. Indeed, clinical trials have always been a crucial piece for individuals that have an unmet clinical need. As we have more lines of therapy for diseases, there are more options available to patients. There are more options available to treating physicians. This certainly competes with the availability of clinical trials. As an individual that focuses on hematologic malignancies, again, whether it's acute myeloid leukemia, chronic lymphocytic leukemia, non-Hodgkin's lymphoma, there are truly dozens of new drug approvals each year, and this certainly crowds the space for clinical trials. Next, I would highlight the expense. For patients participating in studies, there is both a hassle factor, time, extra visits, more frequent monitoring. There can be additional financial challenges. Usually, the actual care delivery itself should be, in theory, neutral to the patient, with the standard care expenses being charged in the normal fashion. But it's these other aspects, particularly if travel is involved, that clearly are a challenge for patients going on to the studies. Next slide, please. Additional concerns are those historic concerns of being a guinea pig for research. And to some degree, a patient, as they bring in their preconception of research, clinical trial research, and where that fits, is an important part of this issue. Patients sometimes have a concern by going on a clinical trial, am I opening myself up to greater toxicity than I might with standard therapy? Finally, I'd say that the bombardment of medical information in the lay press can be very confusing and be its own challenge. So for example, when a major impact is made with a major discovery, a couple of years ago, the impact of CAR-T therapy for leukemia was highlighted. And that, of course, we know was in specific populations with ALL. However, every single patient with a blood disorder, typically asked about this breakthrough. Did it apply to them? Could they get on that clinical trial? And would it be a resource for them? And as we weave through all of that barrage of information, that is an additional piece. Next slide, please. What are some additional challenges that might be specific to underrepresented minorities? I'll share a couple slides that were generously shared by Dr. Shepard, who had presented these at the 2017 AACI meeting as relevant to this topic. And for their cancer center, the population in question, which they were really trying to serve and support, were African American patients in particular. Next slide, please. They had done research with 22 African American patients who had declined clinical trial participation. And with these structured interviews, they found that there was fear of additional burdens that could be financial, that could be physical, as well as fear of adverse events. Additionally, they found that frequently there were family members that might have mistrust against participation. Indeed, that support unit for the patient is an important part as we think about many of the different cultural groups. Indeed, as I will discuss, our Hispanic patients and some of our efforts here in San Antonio, we have found that broader family is key. We have learned to regard informed consent as almost being a family-based process. If the grandmother is going to go on a cancer clinical trial, if her grandson is an important voice of advice in her life, if they are not looped into the informed consent process, they may well be a barrier for her either participating, remaining on the study, or complying with the study. Our colleagues from VCU also identified that these patients with the interview might consider participation if they had been given access to a decision aid, which helped to greater educate regarding the trial, as well as the ability to discuss it in greater detail with their provider. Next slide, please. Additional barriers which were identified were the concerns of burden as it relates to having to undergo more testing, more office visits, lost time at work, and even transportation. Clearly, the concerns of being a guinea pig are a concern, and they are certainly not solely in our patients who are underrepresented minorities. Many patients don't understand necessarily well the benefit of participating in a clinical trial and why that is a benefit to them in terms of being able to receive a new therapy that may have efficacy that they otherwise would not have access to, as well as sometimes the benefit of the great scrutiny and intensity of care that one receives on a trial. Additionally, concerns about side effects can be a concern. Indeed, any of us that have read an informed consent document, realize that these are very intimidating documents for our patients to read, and that the sheer length of the listed side effects can be very frightening and off-putting to many patients. Next slide, please. Now, I'm going to pivot from more the general group and focus a bit on the population that our cancer center serves, which are Hispanic patients. And this talk I had initially put together for a meeting which we held earlier this year in February of 2018, led and organized by my colleague, Dr. Emily Ramirez. And I'll be highlighting much of her work, and that she's really been a wonderful figure in this arena and has done much research regarding the enrollment of minorities onto clinical trials, as well as efforts to try to improve that. Now, as we had that meeting on cancer in Latinos, we recognize well that even within a population, we're talking African Americans, if we're talking Native Americans, if we're talking Asian and Pacific Islanders, if we're talking Hispanics, these are not monolithic groups. These are very heterogeneous groups with different populations and different cultures, different ethnicities woven into them. Indeed, as I have spoken with the chair of our Physicians Clinical Leadership Initiative from AACI, Dr. Ray Holcomb, who is the director of the Cancer Center in Hawaii, as we've discussed the Pacific Islander population that they serve with their cancer center. Again, that ends up being a very heterogeneous group that has very distinct issues than my center faces with our care for Hispanics. But that granularity is some of the richness that their center is able to bring to that equation for studying, as well as hopefully our center is able to bring for our population of Hispanic patients, and in particular, the population of South Texas, which has its own unique genetic and heritage footprint. Next slide, please. So I'm going to start with some information gathered by our center. Our center, previously called the Cancer Therapy and Research Center, this is a study led by Dr. Emily Ramirez, where they looked at barriers that these populations face in participation in early phase clinical trials. Particularly relevant topic for our center, in that early phase clinical trials have been a crucial part of our portfolio, going back to the days when Dan Van Hoff set up that transformational program here at our center with the Institute for Drug Development. Next slide, please. These were the individuals who either enrolled or decided not to enroll by ethnicity into these early phase clinical trials. So again, think phase 1 clinical drug trials. The observations were that more Latinos decided to decline these particular studies, and that they had a greater concern on the plus side with symptom improvement. So that was viewed as a positive, would help to improve symptoms. There's concerns about hospitalizations. There was hope for potentially better outcomes. There was fear and uncertainty over the experimental treatment efficacy. That was a barrier across all groups, but it was greater in the Latino group, suggesting difficulties with communication as well as really understanding the opportunity. Next slide, please. In parallel with this, there had been efforts that Dr. Ramirez and other collaborators outside of our center, but from other centers that care for similar populations in San Francisco, San Diego, etc. And they wanted to look at it from the physician's perspective. In particular, the Latino physicians that are their attitudes and practices and how this may impact the accrual of Hispanic patients onto clinical trials. Overall, they found that this group of physicians felt less of a connection with clinical trials. They saw less value in clinical trials, and they came away with a strong sense that this was an opportunity for better education and engagement in this key group of physicians that frequently cares for a larger percentage of Latino cancer patients, and that they are a key portal to serving these individuals. Next slide, please. This was a study led by my colleague Ron Go from my prior institution of Mayo Clinic. And here they looked at the racial and ethnic differences in clinical trial enrollment across community cancer centers. So this was really meant to complement the experience that might be present at the larger cancer centers that may have a different demographic, different workflow, different expectations of patients. Their takeaways from their analysis was that ineligibility on the studies due to comorbidities tended to be higher in non-Hispanic Blacks, less of a factor for the Hispanic patients in this study. They found that the consent form readability was an issue across the board. However, in this particular study, they found that in community cancer centers, they did not feel a strong differential in terms of decreased enrollment of Hispanics. Mentioning this topic of translated consent forms. Consent forms clearly are very challenging documents, and we're all instructed to aim for the language of those consent forms to be somewhere in that 6th grade reading level. The challenge when one translates a form is how effectively is one actually translating the intent of the communication which is being expressed. Indeed, frequently, direct translation word for word, will lead to a document that really tends to not be very understandable and clearly does not get the intent across. So that piece has been one, as we get around to potential solutions, that my center has tried to look upon as we look at consent forms. Next slide, please. This was a complementary focus group study looking at impact and underrepresentation of Hispanics and other minorities in clinical trials. This was the perspective for focus groups from clinical trial recruiters. So these are, again, we're surveying the recruiters. The key points for these individuals included it's important to adapt to the potential participants' language competency and literacy levels. Engaging in culturally appropriate verbal and non-verbal communication as important. The importance of establishing a sense of connection between recruiters and patients. The issue of accommodating socioeconomic concerns. Indeed, for my center in San Antonio, the ability to provide transportation to the center is an important piece in being able to serve this need. This is a much more significant issue than it was in my prior center. So again, center and community dynamics being important. Important to adapt to contextual factors, as well as understanding and responding in a way that clearly is understandable in the individual's native language about potential mistrust of medical research. Next slide, please. Now, what about the rural versus urban piece as it relates to underrepresented minorities? This was a study that looked at barrier to clinical trial participation and a comparison between rural and urban communities in South Carolina. And in this phone survey of residents, their key takeaways was no significant difference in willingness to participate based on rural versus urban. There was distrust and fear of clinical trials in both groups as a potential barrier. However, rural patients clearly had a perceived limited access to clinical trials, and they had a greater lack of knowledge regarding clinical trials. Next slide, please. So what strategies might we employ to help to facilitate clinical trial participation and to enrich that participation by underrepresented minorities and using Hispanics as one example? Next slide, please. So one, what about improving accrual overall? This was a study recently prepared and now submitted for publication from my center, as well as colleagues from the University of Colorado. And they actually looked at a predictive model of trial accrual and found that the type of study did make a difference. Observational, interventional, and industry-sponsored trials authored by the local PI were more likely to meet accrual goals. Again, not a surprise that if there really is a strong local stakeholder, that is a central piece. Indeed, clinical trials, I think, are not things which exist in a vacuum. They really need to flow from the passion of our cancer center investigators. They need to match up with the needs of our patients. They need to match the patients that we're actually seeing, and they need to match the clinical situations that our patients are facing. Next slide, please. Some examples provided by Dr. Shepard at the AACI meeting. Next slide, please. Included these examples. First, dedicated resource specialists. Again, whether it was understanding of the clinical social workers and their ability to help them to support the patient so that they could adequately participate in their care. That can be transportation grants, childcare, legal assistance, co-pay assistance, etc. That additionally allows the clinical research nurses being able to focus on the care-related issues as opposed to some of these other social and logistical barriers to care participation, and clinical trials being a piece of that. Next, the insurance coordination. Indeed, this remains a challenge in that, again, certain insurance companies may, depending upon the benefits open to the patient, may have an initial barrier for patient participation in studies, so that the better we're able to coordinate the financial aspects of care, the easier that this piece is facilitated. Next is communications training, with support services for clinical trials being utilized at their center. Next is education and marketing. Indeed, this center promotes their trials, not only in their clinics, but also within their larger health system and at community events. Additionally, they have leveraged key messages about clinical trials through faith-based health fairs, community gathering, and urban radio campaigns. Indeed, I am aware of as well that there is an initiative from the National Black Churches and their leadership to partner with the NCI as well as NCI centers to create both greater awareness around cancer clinical trials as a resource for their members, as well as to increase that participation so that as cancer therapies are being developed, they are both effective, safe, and aligned with their members and population. Finally, they included specifically testimonials from other individuals who are African American who participated in clinical trials and their experience. Indeed, that is a very powerful tool. Seeing individuals that are of a similar circumstance, background, race, or culture, and that they participated, found it beneficial, that is an incredibly important resource. Next slide, please. They have utilized automated data screening tool for trials. And indeed, there are increasingly different platforms available for centers to be able to identify populations that they have present when determining whether to take on a new clinical trial. You know, if it's a fourth line study for neuroendocrine tumors, you know, how many of those patients do we have? Is that trial only for, you know, women with red hair? Again, it starts to further splinter the pie. You know, so one, you can get an estimate on the front end, you know, how many patients does your center really see with that sort of condition? On the back end, if it's once a study opens, it can be a way to identify patients within your system which might benefit from that study. Next slide, please. Now I'll pivot to some of the solutions we've tried to put in place in our center. And I will certainly share that it is a work in progress, but it's an area of great interest and passion for us. So our catchment area as a cancer center is San Antonio and South Texas. And this population is about 69% Hispanic, 24% non-Hispanic white, 4% African American. The main population in this group is along the Rio Grande Valley, as well as in the San Antonio area, with the areas in between being very rural areas. This overall has a population of just around 4 million individuals. Next slide, please. Our center, recognizing this opportunity, both my predecessor, Dr. Ian Thompson, Emily Ramirez, and other members of our cancer center did this very nice effort to develop a minority recruitment plan for cancer clinical trials. And what they did was create a toolkit that included many things, including clinical trial information, both English and Spanish, on our website. Use a bilingual research team member or formal translation services for translating of materials. Identification of bilingual patient navigator, representative of the target population. Having the informed consent available in Spanish, and informational brochures which are IRB approved in both English and Spanish. Depending upon the study, having flyers in English and Spanish, or have it two-sided, printed in English on one side and Spanish on the other. And again, as with all recruitment materials, these need to be IRB approved. Depending upon the study, public service announcements on Spanish radio, public service announcements or advertisements on Spanish newspapers, public service announcements or advertisements on Spanish television. And again, with studies, these are directly around IRB approval. In parallel with this, I will add that we have added trying to create awareness of clinical trials as a strong resource which flows from our center, as well as a resource for these populations that we discussed with earned media pieces on Spanish radio or on Spanish television. Patient-friendly fast facts in English and Spanish. Next slide, please. This shows you a bit of the strategy with and how it fits into our plan. There are many resources we weave into this process. We've engaged our own internal wellness center. We have many community groups that we have linked with, the San Antonio Cancer Council, the Alamo Breast Cancer Foundation, the San Antonio chapters of both American Cancer Society and LLS, Redes en Acción, another group serving these patients that we look to assist. Susan B. Komen grants, which aided Latina access in breast cancer clinical trial enrollment, was a piece in this equation as well. Next slide, please. We created a specific minority accrual committee with 10 members, with the focus of this committee to reduce barriers to minority patient accrual and to implement the strategies I mentioned to enhance minority recruitment. There is a coordinator of minority programs, Leticia de los Santos, who is a resource for this. There is a minority accrual plan which is required for all clinical trials at our center, with the list of options available in our toolbox, which were developed to help investigators create their plan per study. And then we monitor this with studies as we would otherwise with accrual, safety, etc. Next slide, please. So first, we identified barriers through research, focus groups, interviews, and physician outreach. We developed strategies and materials which we discussed. In parallel with this, we have conducted virtual tumor boards for the centers in the Rio Grande Valley, who we help to support, where they care for up to 90% Hispanics in their practices, and our expanded media outreach. Next slide, please. These were the toolbox, things which I had mentioned: the consent, the team members, the PSAs, flyers, advertisements, etc. Next slide, please. With these assessments, this was implemented in August of 2013. We had, through 2013 to 2007, 226 studies that had a minority accrual plan with a minority accrual metric of 33% or better for each study going through the mix. With this intervention, we increased the accrual from 46% to now 57% Hispanics going on to our cancer clinical trials, starting to approach the percentage in our population. Next slide, please. And this showing the impact across the board in minority accrual. Next slide, please. This shows on interventional non-treatment trials. Next slide, please. And this shows in the observational and correlative studies. Next slide, please. Additional efforts, this just came out recently from Dr. Ramirez, is further ways to empower Latina breast cancer patients to make informed decisions about clinical trials. And here, again, they had a intervention, which they labeled choices, which made it clear and easy to understand the clinical trial information. They included videos, they included social support and reinforcement. They included assessment of treatment options, risks, and benefits. They included coordination of care and navigation services. So this was a package of resources pulled together specifically that would be available for individuals who were Latina with breast cancer to try to link them with clinical trials. And it focused fundamentally on better understanding of the clinical trial and then consideration of clinical trials when appropriate. Next slide, please. So what are the next steps? Next slide, please. I would say that the key opportunities that I would focus on before we pivot to open it up for questions is first, education of registering physicians. Indeed, a patient can only enroll on a clinical trial if the physicians not only understand this process, but really find the value. Why is it important that these patients enroll on clinical trials, inform our understanding of the biology of cancer, inform our understanding of the biology of cancer in that specific population, the ability to develop better targeted therapies that are both relevant, safe, effective, whose toxicity is understood in our diverse population. Next, awareness building amongst Latino populations of the role of clinical trials in improving cancer care. Indeed, that preconception regarding a clinical trial is important. And that preconception is important not only for the patient, but also for their support structure, their loved ones that help them to make the decisions. If the grandmother with cancer has, again, a grandson who is a key influencer of her healthcare decisions, and that grandson has a strong preconceived negative opinion regarding clinical trials, it's going to be very difficult to get that individual to either enroll or to comply. Again, successful completion of this goal is not only for people to enroll onto a study, but to truly participate and follow the clinical trial as it is set to do. Compliance with the study, with the visits, with the metrics that need to be done are crucial, not only for participation, but for that data to be valuable. Third, care navigation enhancement to better support the role of cancer clinical trials is crucial in care treatment planning. This is true really across the board. This clearly is not limited to underrepresented minorities in any way, but that whole part of demystifying the process, decreasing the logistical hurdles, or at least facilitating the ability for a patient to overcome those hurdles is key. Fourth, enough cannot be said regarding the both language and culturally appropriate materials, education, and clinical trial coordination. Indeed, if an individual does not have English as a primary language or has limited ability to communicate in English, it's not only about having an informed consent in Spanish. Do you really have the support for that individual to be able to interact with both the healthcare team and the clinical trial coordinator in their language in a way that they really understand? Are there surveys that they have to fill out? Are those surveys in their language? Do they understand how to access that? Do they really understand if there is a home component with tablets? Do they really understand the schedule? Is there a pill diary that they have to fill out? And do they really understand that piece? So there's so many aspects of really appropriate compliance that really mandate good communication and have to be sensitive if there is limited health literacy. And finally, the sharing of the lessons learned between the centers engaged with different populations is important. Having come from the Mayo Clinic in Arizona prior to moving to San Antonio, there we had issues with patients of Hispanic origin going on clinical trials. That was one set of issues, but the population was different. In many circumstances, those were patients that had recently moved from Mexico. And culturally, there were distinct differences from the Tejano population here in San Antonio, where people have been here for generations. There is a different culture. Native Americans, African Americans are both heterogeneous populations, but each bring to the table different cultural pieces, different history, different preconceptions around clinical trials that both you need to be aware of, and sometimes really need to be addressed for us to be successful in these areas. Next slide, please. So with that, it's really been an honor to be able to share some of these observations, both from my center as well as some colleagues which generously shared other slides. I've left us some time for some questions that I will certainly do my best to answer. And again, my thanks to the AACI for the opportunity to share a bit of these insights with you today.
Thank you very much, Dr. Mesa. We do have some time left for a few questions. So if you would like to submit a question, please submit one using the box on the lower right. So we do have a few questions. The first question is, do you think that the complexity of modern day consent forms disproportionately affects enrollment of Latinos and other minority groups?
It's an excellent question. I think to some degree, potentially yes. You know, as a group, the health literacy may, certainly in some populations, may be more challenged without question. I think informed consent forms have evolved to be such legal documents that really are designed to, mitigate, the risk for the trial sponsors. But their ability as really communication documents, I think, is challenging. In the sheer length, scope, and complexity of particularly adverse event risks, is both intimidating and confusing for many individuals. Additionally, the terminology regarding some toxicities is frequently not in a 6th grade level language, and that too can be a barrier. So it's one thing to see a list of risks. It's a second to see a intimidating list of risks in which you don't fully understand some of those risks. It's always challenging because the second part, patients don't necessarily see a parallel informed consent for standard of care. That discussion of risks and benefits that come with standard of care that typically is more verbal may seem disproportionately less concerning.
Okay, the next question has multiple parts. Can you please elaborate on the VCU Massey Communications Training Support Services for Clinical Trials brochure for patients, physicians, and healthcare staff? What was included in the communications training? Or was this simply a brochure about what clinical trials are?
My understanding is that that particular part was a brochure but I would certainly direct individuals to our colleagues at VCU to learn further about that.
Yes, and if you have further questions regarding that previous question, you can submit them in the evaluation and we can pass them along. The next question is from a community clinic. The question is, I understand that emergency medical assistance, or EMA, provides coverage for cancer treatment if it is not in remission, including surgery, chemotherapy, radiation, and related approved services. Will EMA ever provide coverage for treatment received as part of a clinical trial?
It's an excellent question. I would certainly advocate that it should. You know, without question, clinical trials clearly have a symbiotic relationship with standard of care. So, for example, even for an emergency service, if there were, let's say, more than one way that we might impact cord compression, you know, certainly we would want that to be able to be covered. So I think for the moment, there remains a cultural piece, I think, both with payers and regulatory bodies that slowly is improving, but that clinical trials should not be looked at as a luxury or as separate from care. They're an integral part of care. As an adult cancer specialist, I'm mindful that, you know, less than 10% of adults go into cancer clinical trials. However, in pediatrics, our colleagues have been successful in making the case that, with few exceptions, our cancer care always has the opportunity to improve. And because of that, the culture has been amongst physicians, centers, and the parents that make these treatment decisions that the standard of care in pediatric cancers is enrollment onto a clinical trial, so that the enrollment rates onto pediatric cancer clinical trials is really for the majority of patients, as opposed to the minority.
Thank you very much. The next question is, you mentioned the recruitment committee. Does that include internal staff and community members?
Yes, so there is a community member that participates with that group to really act as a resource for the ability for the you know, a sampling of the consent forms to be that they are readable, that they are understandable, as well as for that important community perspective. Yes.
Okay. You mentioned how your cancer center promotes clinical trials at community events and faith-based organizations. But given the sensitivity of cancer clinical trials compared to other types of research studies, how do you approach these organizations most effectively? Especially if only a fraction of its members are affected by any given cancer, the eligibility for clinical trials are increasingly more narrow.
It is an excellent question. In general, for larger events, it's about promoting cancer clinical trials as a group of options as opposed to one particular study. I will say larger studies as they relate to the general population, such as colorectal cancer screening, mammography. When I was at Mayo Clinic in Arizona, we had a breast density study for Latina patients. So there are examples of studies that have much more broad general public applicability, but primarily in the prevention and screening space. But in large groups, we certainly do try to aggregate clinical trials as an option to promote, as well as a strong resource for them to consider.
Okay. Do you use clinical informatics to pre-screen or identify patients? And if so, when and how?
So we are currently evaluating, there are now various both software platforms that can intersect with the electronic medical record for screening of active patients, you know, under your care based on eligibility criteria by diagnosis, by organ involvement, by the organ function, etc. What we have found is that one key piece of this is, being sure that the data in the EMRs is precisely in the format that these tools can leverage. So, for example, if there's a staging module, it's crucial for this data to be able to be utilized that the staging module be leveraged to its fullest capacity versus having free text entry of staging or features into the notes of the individual physicians. I know there are efforts ongoing that are looking at IBM's Watson and other things to be able to do, natural language processing to be able to scour the actual physician notes to a greater degree as well, although I think those efforts are further behind.
What recommendations do you have for embedding this important knowledge into the training of physicians who train to manage clinical trials?
I think it's a very important piece without question. I think as we train our physician investigators, I think there are many levels. I think a sensitivity to the process and the complexity of being a patient participating in clinical trials, I think is important. I think, having to look at it from their angle, I think is key, in particular with this extra level as it relates to underrepresented minorities. But how many blood draws is it going to take? How many extra visits? Are there preconceived notions that are important based on culture, based on
Dr. Mesa, you cut out again. Can you please check your connection?
Okay, well, we seem to have lost Dr. Mesa. So we'll go ahead and end the webinar. I'd like to thank you for attending the webinar today hosted by AACI's Physician Clinical Leadership Initiative. The slides from this webinar will be emailed to you following the webinar, and we will also follow up with an evaluation link. Your feedback is very important to us as we plan future webinars. If you had any extra questions you'd like to ask Dr. Mesa, you can also include them in this evaluation, and AACI staff will be sure to pass them along to him. Thank you again for joining the webinar, and have a great day.
Great. Thank you very much.